morning. I'm Senator Liz Boldon. I represent District 25, which is the Rochester area. We are here this morning because with just 4 days left in session and policy negotiations ongoing, there are about 250 families across the state with kids with complex medical needs who are counting on all members of the legislature to stand up for them and ensure insurance companies are held accountable to cover the care that they need and that is currently required in law. This is a straightforward issue. In 2010, the legislature passed an insurance mandate into law with crystal clear intent. For people on medical assistance who also have a commercial health insurance plan, the commercial plan is responsible for covering the cost of home care nursing services. This is continuous, medically necessary care that keeps these kids out of the hospital and at home with their families where they should be. For 16 years, commercial plans have followed this mandate without issue. That changed this year. Medica and Health Partners added a cap on coverage of this care that amounts to about 10 days. What happens for the other 355 days of the year? The insurance companies want those costs to be shifted to Medicaid. That might sound fine, except that it is not what the law says, it is not accounted for in our state budget, and most of all, it would put families' waiver budgets out of balance, and they would then have to make choices about what other cares, services, and equipment they will have to give up. This should be an easy choice. It is not a new coverage mandate. It does not add cost to the Medicaid budget or to commercial plans. It simply takes us back to the universe we all lived in 6 months ago, clarifies the law's intent, and maintains the payment structure that has been in place and working for the last 16 years. The law has not changed. The coverage should not either. We have a choice to make. Are we going to stand with insurance companies who found a loophole to save themselves money? Or are we going to stand with these families? That is a very easy choice for me. And we are demanding that this be included in the Commerce Conference Committee report. And next, I'm really grateful that we have one of those parents here with us today.
Good morning. Thanks for letting us share our story. My name is Kit Chambers, and I live in Plymouth with my son Nash, and I'm here today with his nurse Maddie. Nash is a rambunctious, smiley, medically complex 4-year-old. He depends on skilled, registered nurses, not home health aides, not general caregivers, but nurses, to be safe at home, to attend school, and to thrive in our community. Without those nurses, who we call Team Nash, he could quickly be back in the hospital, where he spent over half his life. Nash has endured over 60 surgeries, 500 plus days hospitalized, and I can earnestly tell you one of his favorite words is still home. For more than 3 years, our commercial insurance has covered the nursing hours Nash's doctor prescribed. That coverage is what kept my little guy out of long-term hospital stays and allows us to read book after book on our couch at home. This year, that changed, not because Nash got healthier, not because the law changed, but because our insurance company quietly decided to reinterpret what they owe us 4 days after open enrollment ended. These nursing hours are not a luxury. They are written into Nash's care plan by his physician. These hours are prescribed, medically necessary care, and Nash is authorized for a high number of home care nursing hours every week based on that medical assessment. Our insurance company is now telling us that they will only cover about 2 days per week. That is not coverage, that is abandonment. And we are not alone. On a daily basis, I hear about other Minnesota families struggling to battle through insurance caps while also juggling staffing nursing, managing appointments, medications, and daily cares. Those families are living with a very real fear that their child's health or even life will be compromised by these insurance companies. For 16 years, Minnesota commercial health plans have understood their obligation under Minnesota Statute 62Q 545 and have covered home care nursing for children like Nash. They are not suddenly making a new legal argument. They are making a financial one, and medically fragile children and their families are paying the price. I expected the most complicated part of Nash's medical complexity would be the life-saving measures his nurses and I have taken to keep him alive. This year, that is not true. Instead, the most complicated part of having a medically complex child would be asking insurance companies to be held accountable. When commercial insurance walks away, that cost does not disappear. It shifts, It shifts to Medicaid and onto Minnesota taxpayers. Estimates put that shift at roughly $75 million or more in state funds alone. And the alternatives to home care nursing, repeated hospitalizations, emergency room visits, or institutional placements cost dramatically more and are far worse for our children. This is not true savings, this is a cost shift, and one with a cascade of fiscal consequences. Part of how we got here is a basic misunderstanding about what kind of care we are talking about. There seems to be some confusion within health plans between home health and home care nursing. Those terms sound similar, but they are not interchangeable. Home health is short-term, episodic care. Think of a nurse who visits a few times a week to check a wound, or a therapist who comes for rehab after surgery. For people who are mostly stable, that works well. Home care nursing is completely different. It is continuous, skilled medical oversight for children who are medically fragile or medically complex around the clock. The children in our community that are the highest risk are on a ventilator for respiratory support, eat via a feeding pup, need oxygen, have wound vacuums, dialysis, TPN nutrition, seizure monitoring, and more. These services require a registered nurse present to manage life-threatening conditions, not periodically, but continuously. For many of these kids, if nursing interventions are not done within minutes, a child's life is at risk. Emergencies do not happen in a vacuum. For Nash, he once decannulated himself at a Twins game, and without immediate intervention, he would have stopped breathing, and he wouldn't have seen the Twins beat the Brewers. When you take limits designed for short, intermittent home health visits and apply them to kids who need 16 to 24 hours of home care nursing, you're not just making a paperwork issue. You are creating a clinically dangerous situation. These are different services, different populations, and different levels of medical need. Conflating them puts children like Nash at risk of ending up in the ICU when they could have stayed safely at home. From a fiscal standpoint, this should be incredibly straightforward. One home care nurse caring for a child in their home costs a fraction of what that child would cost in a hospital bed, especially in intensive care. A night of home care nursing may cost hundreds of dollars, but a single night in the pediatric ICU can cost tens of thousands. When you cap nursing and create gaps in coverage, you invite more emergencies, more hospitalizations, more pressure on Medicaid, and higher insurance premiums. That is the opposite of cost control. And there is really no way to measure the vast difference between kissing your child goodnight in their own bed instead of over a hospital railing. HF 4188 steps in here. It explicitly prohibits quantity limits on home care nursing services and clarifies how these services must be defined in health plans for people who have both private insurance and medical assistance, like my family. It does not expand who is eligible for this level of care. Doctors still make that determination using the same criteria they always have. It simply says that once home care nursing is authorized, insurers cannot quietly hollow it out with arbitrary visit limits that treat ICU-level care as if it were a handful of home health visits. We're not asking for something new. We are asking for the law has always required, and what families like mine have relied on for more than a decade. HF 4188 gives the legislator an opportunity to reaffirm that Minnesota will protect its most vulnerable children and prevent a very expensive cost shift onto Medicaid and Minnesota taxpayers. My child deserves to be at home, to be safe, to be with his doggies, to see his cousins, and to play in our neighborhood with a nurse carefully in tow. He deserves to have the care his doctor has already prescribed, and that should not be controversial. Supporting this is about 3 shared values that should transcend party lines: keeping children out of the hospital when we can safely do so, using healthcare dollars wisely in the most cost-effective setting, and making sure that families can trust the coverage they pay for will be there when their child depends on it. I've watched Nash fight for every breath. I've watched him spend months and months of his life in the hospital. I know exactly what it cost in money, in trauma, and in lost time to keep a child in the ICU instead of in his own bedroom. It's simply smarter and more cost-effective to keep medically complex children stable at home with the home care nurses they need than to pay repeatedly for avoidable hospitalizations. So I'm asking you, especially those of you who are skeptical or undecided, to look at this as not a bipartisan bill, but as a correction of a mistake and a commitment to basic compassion and basic decency. Let's keep kids like Nash in their homes with their families and where care is the least expensive. Please support HF 4188 and put an end to visit caps on home care nursing. Thank you.
Hi, my name is Erin Cagle, and I represent District 39A, which is Fridley, Hilltop, Columbia Heights, and Spring Lake Park. And I'm really grateful to these families, especially for being so brave to share your stories. This is my niece, Isabel, and she passed away 5 years ago. I haven't prepared any remarks today because I just really wanted to know that I've seen how this affects families personally and up close. And on the back of this is all of the nurses and home care workers and PCAs who supported her through her life. We're talking about really vulnerable kids who deserve to be home with their families. This is not something that we should be here doing. This was already settled coverage. And so I just really want to focus on how much it not just affects the children, but affects the parents, the extended families, the PCAs, the nurses, and in my niece's care, a lot of the hospice workers. And Crescent Cove was amazing at the end of her life. And so she had the care she needed. So imagine what would happen if she didn't. So, thank you.
Thank you.
I'm sorry your family is going through this. I'll turn it over to Senator Klein.
Thank you. I'm Senator Matt Klein, representing District 53 in the legislature, and I'm a physician at Mayo Clinic. I'm, along with Rep. O'Driscoll and Rep. Cagle, I am chairing the Conference Committee for Commerce and Consumer Protection, where we heard from families yesterday like this one, and a parent who told us that his child has been in the hospital for the last 5 months when they could have been at home with good home care. And I can tell you, in my experience as a doctor, that is trauma. That worsens outcomes for kids. It traumatizes a family and it traumatizes a young person, and it's unnecessary. There is a very clear distinction, as you've heard, between home care visits and home nursing services. It's in our law, it's in our statutes, and it has been misinterpreted by the health plans and by the Department of Commerce. We need to correct this immediately so that these children and these families return to the good care that Minnesota expects of our neighbors. I will say that in the Commerce and Consumer Protection Conference Committee, we've completed our work. We are ready to close the bill, but we have left it open because the 3 chairs feel so firmly that this needs to be resolved this session. We're going to keep it open for the remaining 4 days of session in the hopes that an agreement can be reached and we get this work done. And I'm grateful for the presence of the family here today.
Thank you, Senator Klein, and thank you for being here and giving this some attention. I'm Representative Robert Bierman from 56A and current co-chair of the Health, Finance, and Policy Committee in the House. And I want to thank the families who have come and spoken to legislators and spoken in front of committees and told their stories. It's just very impactful to see what this change in health policy has done to families and the children. So you've heard the detrimental effects of this reinterpretation of state statute by Medica and health partners and what it's doing to vulnerable children and their families, some of the most vulnerable patients in our healthcare system. We should not have to be creating a fix for a law, as has been mentioned, that has been in statute and insurance companies have complied with for 16 years. We shouldn't be having to go back and address this in this way. The testimony and the intent of legislators, if you read the 2010 hearing, as was mentioned, it is crystal clear. Questions were answered, asked and answered, and it was crystal clear. So the decision in 2010 was to shift these costs onto insurance, not the state. And the lack of regulatory enforcement by the Commerce Department at this time will put costs back onto the state. Last night, we just got a budget agreement. There is no extra funding to cover additional costs from the state budget, nor should there be for this. Our bill will fix this, and I urge its passage by the Commerce Committee that is still holding it open, as was mentioned. Health plans are not lawmakers. They can lobby for change, but rewriting their coverage benefit plans should not override state mandates that have been on the books. This is a horrible precedent, which gives me great concern. Thank you all for being here, and I think we'll take questions, and we have bipartisan legislators here who are ready to stand for questions as well, but ready for your questions at this time.
Are you pretty confident this bill can get through both the House and Senate before the deadline?
I've learned over 8 years never to make predictions, but I think we have the support for this bill, like some others that I still hope to get across the finish line. This is imperative to do, in my opinion, and I think that we need to really focus in these last few days and make sure that this is one of the things that gets done.
It'll be carried as a standalone, not along with another bill.
Again, weird things happen at the end of session, but it's in conference now, yes. So it is ready to be put into that package and moved forward. And so, you know, we always want to have Plan Bs if that doesn't happen. But I'm urging passage of that bill from the committee at this time.
If the language was crystal clear 16 years ago, what is the new language that will eliminate the insurance companies from shifting these costs?
It's a short bill. It just says that there is no, you cannot put a cap on it. What happened was they changed their benefit plans for this coverage, but when you, as was enunciated, when you change that benefit plan on coverage that doesn't apply to home nursing care, then you're changing something entirely different.
I just want to be really clear. This is an effort by insurance companies to save money. The law says that this, and I went back and listened to the hearings in 2010. I wasn't here at that time, but it was very clear. Questions were asked and answered. This was a mandate for private health plans to cover this care. And so the law says that they must cover this care. The plans are coming in saying, well, it doesn't say that we can't put a cap on that care. That was not the intent of the law, but it is a tactic that they are using to save money. And what that means then for these families is it has huge impacts. And so again, it's a precedent that we cannot let stand. So the language just clarifies the law that says, okay, you know, you're trying this tactic, you can't put caps on it. When you have to cover it, you have to cover it.
Can I add that? Sorry, real quick. Representative Andy Smith, District 25B, I'm one of the co-authors in the House on this bill. We've talked a lot this session about fraud. What is fraud but a private company not providing the service that they are saying they are providing and taking taxpayer money and profiting off of that? We need to hold all of those folks accountable, including those folks who can hire expensive lawyers to reinterpret the laws and who can hire lobbyists to come and make that case here in this House. What the insurance companies are trying to do is reinterpret a clear law to save money while still fitting the bill, having taxpayers fit the bill. And we are trying to stop that level of higher corporate fraud, in my opinion, as well as we have taken measures to stop other kinds of fraud this session.
And I just want to add too that since this provision has come, since the letters were mailed out to the families, it has put a ton of stress on these families trying to scramble to find coverage, figure out if they are covered or aren't. And so just imagine having to go through that scramble to try and get life-saving care for your kid.
Let me just offer a thought. I'm Jim Abler from Anoka. This is not a partisan matter at all. It's just simply a matter of right and wrong. Pastor Irv taught me, it's never right to do the wrong thing. It's never wrong to do the right thing. It's never too late to do the right thing. Let's do the right thing. Thank you.
Any other questions?
Thank you, everyone.
Thank you, folks.
Good job.